All right, give us a few minutes to let people come on in, and then we will get started. For those of you who are just catching this on the replay, I do want to say welcome and thank you, everyone, for joining us for this, the first of our EPICC review course student, you can call it office hours, you can call it our monthly webinar, whatever you prefer to call it. But let's see if this is going to work. See if I can actually hear you guys a little bit better as you start to come in. So, perfect. All right. So for those of you that are just coming in, I just want to welcome you again and let you know that this is going to be a monthly webinar. We're going to do it on the last Tuesday of each month, and you will be getting an email notification from FlightCrit when we schedule these. They're pretty much already scheduled, but we'll send out a reminder to everybody with a link to the actual webinar each month. This is going to be your opportunity to hop in and consider this like, I call it office hours because it gives you an opportunity to communicate with me directly. But I think what's most valuable about this is that it gives the students that are in the class an opportunity to kind of come together all in one place at one time and ask questions of each other and of myself and future instructors, so that you're really getting the most out of the course. Of course, that's ultimately the goal here, is to help you achieve whatever goal it is that you are hoping to achieve from the EPICC review course. If that is renewal, if that is just learning new content and staying fresh, if that is getting ready for the actual FPC review, or the FPC exam, or the CCPC exam, or even the CFRN exam. My goal is to help you accomplish whatever it is that you're trying to accomplish. So today, the things that we're going to cover when we kind of really kick this off is I'm going to take some questions about the current material that is posted on the review course and see if I can clarify any questions that might have come up. I'm going to go over just briefly with you the remaining lessons to be posted, and then I'm going to ask for some suggestions. So maybe be thinking about that, and what suggestions you might have as far as how do we improve the course down the road? How do I make it better for you, the participants, the students, to get more out of it? And then we're going to do a quick review of hemodynamic monitoring. Primarily, I'm going to go over the 4 primary values that you're going to need to know for the exam, and try to cement in your mind a way to think about hemodynamic monitoring, so that when you are sitting down and you're taking the test, if you kind of get stumped, you can kind of critically think your way through the question by understanding the physiology and why the numbers are the way they are, and why blood moves through the heart the way it does. You'll be able to kind of then start to formulate an idea of why the patient may be presenting the way they are and how you might best manage that patient. So we're going to give this a few more minutes for some more people to pop in. Once you do come in, well, for those of you who are catching this on the replay, it's not going to work for you, but we do have a chat box up that you'll see me glancing up at from time to time to see what questions are coming in. And then for those of you who are catching this on the replay, if you think of a question that you want to ask, go ahead and leave that in the comment section below this post, whether it's on Facebook or if it's actually over at the replay page at flightgrit.com. Okay, well, let's kick this thing off. So, as people come in, so for those of you who are going to be watching this on the replay, because it doesn't look like there's anybody that's going to be hopping into the webinar, at least not right now. Hopefully, people will come in as we kind of go along. I want you to ask questions about the current material that is published on the review course. Let me know, what you might be struggling with. If you're not struggling with anything, then I'm doing a great job, and I'm happy to hear that. But I'm assuming that there's probably some questions out there, so you can leave them in the comment section below this replay. Okay, so just to kind of cover where we are with Flight Crit and with the EPICC review course. I've done 2 launches now. The first one was last year. For those of you who got in on that initial launch, thank you so much. You guys know who you are, and you have really made this a reality for me and for so many other people. So thank you very much. There is, let me show this to you. So if you were part of my most recent launch, you know that I decided to become a donor or a contributor to Foundation 1023. Now, if you don't know what Foundation 1023 is, Foundation 1023 is a nonprofit organization that was founded in order to provide mental health support to first responders and their families. Let me switch over and show you what this is all about. So here we go. Boom. So there you go. So Foundation 1023, this is their website, and this is an amazing organization because they are raising funds to provide this mental health resource to anyone in our community who needs it. And it includes not just first responders, firefighter, EMS, police, but also their families. And it's offered free of charge. So if we just kind of scroll through here, you can kind of see what's going on. They have multiple fundraising events where they raise money to support their cause, so that nobody is required to pay out of pocket to receive these benefits. If we come up here and take a look at the services, okay, these are a list of providers that they have in numerous areas around the country, and they are growing, which is just phenomenal. So if you are in one of these areas, they already have providers available for you. But even if you're not, reach out, ask for help. If they can't provide somebody in your immediate area that can help you, they will get you set up with somebody who can, one way or the other. And so you can always come here to their service page and request assistance. And then here on their homepage as well is a link that you can use in order to request help. So if you are having any kind of problems right now, suicide, stress management, etc., family management, or family marital problems related to your work, they can get you help. Okay, so because of the donations, because of your commitment to Flight Crit and the EPICC review course, we were able to donate almost $1,000 to support this cause. So Thank you. That's all I can say is thank you very much for supporting Foundation 1023 through your enrollment in the EPICC Review course. I'm going to continue to donate 5% of all proceeds that we make through the enrollment of students just like you to this foundation, because I think it is a tremendous organization. So thank you very much, everybody, for your commitment. If you are not interested in joining the review course, but you do want to find out more information about Foundation 1023 and support their cause, you can go to foundation1023.org, and you can find out all the information you need to know right there on their website. Okay, so what do we have coming up here in the near future? We have, like I said, cardiac and hemodynamics is going to be, let me stop sharing this. So cardiac and hemodynamics is going to be posted here in the next 24 to 48 hours. After that, we have the neuroemergencies. That section is going to be, hopefully that'll be up in the next week to week and a half. And then following that, we've got OB, neonates, and pediatrics. That's going to come out as the next section, followed by general medical, environmental, and toxicology. So we're wrapping things up. The vast majority of the content is written. There's just a few more tweaks that need to be made to the environmental and toxicology section. And then that will be recorded and posted. I am working with my team to get these edited and get them posted just as quickly as we possibly can. We did have a small snafu a couple weeks back where we lost a lot of content, so that had to be re-recorded. Now it's going through the editing phase, so I want to apologize to everybody for that delay. If you have questions about that, you can leave them in the comment section here, or better yet, just email me. The email address is sean@flightcrit.com. That's SEAN @flightcrit.com, and I will answer any of your questions. So I guess without further ado then, unless we've got any questions here, let me check the chat, and we do not. So I'm going to move on to the hemodynamic section. So I want to go over this for everybody because I know that this is a section that so many people have asked for, and this is a big section, and I didn't want to just kind of throw it together. I really wanted to give this some thought. And so this next section, the cardiac and hemodynamic section that's coming out, a large portion of this section is focused on hemodynamic monitoring. That being said, there are questions that pertain to the hemodynamic monitoring and the use of pulmonary artery catheters and balloon pumps. There's questions on both the CCPC and the FPC exam. However, I think based on my experience that people put a lot of emphasis in those topics, the hemodynamic parameters. People stress about that a lot because they think that that's really going to hammer them on the exam. And while yes, there are questions that do pertain to that, I don't think it's as bad as most people expect it to be. Remember, these two exams, they cover the whole spectrum of critical care medicine. And so cardiac and hemodynamics is just one portion. Now, cardiac and hemodynamics overall covers about 20% of the exam, but the hemodynamic portion of that is, like I said, it's only a small portion of that. It may be, 5 or 6 questions. So while it is important to understand it for not only for your practice as well as for the exam, I don't want people to stress about it too much, okay? It's also quite easy once you really understand and think about the physiology behind hemodynamic monitoring. It's a lot easier to approach these questions with that foundational knowledge, okay? So let's actually jump right into this. I am not going to go over pulmonary artery catheters specifically. I'm not going to talk about the insertion of the catheters. I'm not going to talk about necessarily the waveforms in this particular module, although if people are feeling like they need me to go over the waveforms specifically, I'm happy to do that. But what I do want to talk about is the pressures and why the pressures are what they are, and when they're high or low, how you might be able to kind of critically think your way through why those numbers are the way they are. Okay? So let's go ahead and switch on over to our little slide here. Okie dokie. So hemodynamic monitoring. That was just me testing this out. So I'm a camping guy, and that's why I throw this image up in here, because I want you to think about hemodynamics from the standpoint, or I want you to kind of envision a river flowing, and it's this nice, smooth, flowing river. The pressures are pretty uniform. You get areas along the river where pressures might change. The water might be a little bit more turbulent. Maybe there's a rock in the middle of the river that kind of deflects the flow of the river. And on the backside of that rock, the river might be a little bit more calm because of the eddy that's formed as water kind of recirculates back behind the rock. And in the front of the rock, the water may kind of billow up a little bit, kind of pillow up as it hits the rock and then deflects around. Another way to think about this, another analogy that I've heard, is this analogy of an interstate. And you've got cars on the interstate that are moving, and then you have a car accident, and traffic kind of grinds to a halt right up to that traffic accident. And then after the traffic accident, pressures, the traffic, it's a lot less. And then the traffic starts to move at its normal pace after like this sudden kind of reduction in congestion, right? We've all been on the interstate, and there's a wreck, and you're driving along, and the traffic starts slow a little bit, and then suddenly it comes to a screeching halt, and then you finally get past the accident, and all 5 lanes of traffic open up. There's nobody in any lane because everybody got forced through a bottleneck in order to get around the accident. And then as cars kind of fill in, then people redistribute to all the lanes, and then the flow is pretty normal. Those two analogies work very well. Me personally, I like the river one just because I'm a camping guy. So I want you to think about this from the standpoint of where the problem is in the heart is represented by the dam, or is represented by the car accident, okay? And if you put that in your mind, then what you can think about is, when I identify where the pressures are high and where the pressures are low, and narrow it down to the chamber that's just before and just after the problem, right? What you will see is that the chambers just before the problem, the pressures are high, and the chambers that are just after the problem tend to be low. So that should make sense if you think about that analogy. Okay, so if you just kind of think about that, as we work our way through these various hemodynamic parameters, essentially what you're just doing is you're just moving that car accident, or you're moving that dam to a different place throughout the circulatory system. So the first, here we go. Sorry about that. So I created this chart. Many of you have probably already seen this on the Facebook group. I hope that this was helpful for you. This is just kind of giving you a quick rundown of the normal text parameters, the parameters that the texts that are used for the exam consider to be normal. And then in the far right side, there's a column that cites some other normals that you will see throughout other literature. What you need to know for the exam are the numbers that are in this column here. But just understand that as you are going through your studies, you may see these numbers here show up, and you can see that they're, for the most part, pretty much the same. Then I created this chart, and this is designed to help you kind of figure out, okay, based on the type of shock state that the patient is in, what should their hemodynamic parameters be? So the one that I like to throw out, the one I like to highlight is this neurogenic shock. And I throw this one in there because this one, unlike your other distributive shocks, is the only type of distributive shock that will present with a low cardiac index. Okay, and so that's how you can really differentiate neurogenic shock from your other two distributive shocks, which are your septic and your anaphylactic shock. Some people get really tripped up on that because what you'll be looking at is just simply some parameters, and you will be asked to figure out what type of shock state the patient is in. Okay, so let's think about this for a minute. When the body is hypotensive, okay, it will try to compensate. It's going to compensate by either vasoconstricting and or increasing heart rate. Remember, we have cardiac output, and cardiac output is a factor of heart rate times stroke volume. And stroke volume is preload, afterload, and contractility. So preload is fluid coming in, and if you're in a shock state, you probably have a reduced preload. Contractility is how hard the heart is squeezing, and then afterload is the peripheral vasoconstriction. So you have to have enough afterload in order to create a blood pressure. But too much afterload will actually counteract the cardiac output. Okay, it becomes too much afterload, too much peripheral vascular resistance for the heart to push against. So when you think about these distributive shocks, septic shock and anaphylactic shock, you have this, and neurogenic shock for that matter, you have this massive vasodilation. So it makes sense that your SVR, your systemic vascular resistance, is going to be low. In a perfect world where your patient doesn't have any kind of problems with their sympathetic system, their sympathetic nervous system, like I said, the heart is going to try and improve cardiac output. The body is going to try and improve blood pressure. And one of the first ways it does that is by increasing your heart rate. The other way it tries to do that is by vasoconstricting, but like I said, in this case, we have these pathological problems that are interrupting our ability to vasoconstrict. So systemic vascular resistance is low. Cardiac index, right, which is a factor of it's your cardiac output divided by your body mass, your body surface area, and it takes into consideration the size of the individual. We know that everybody should have a cardiac index between 2.5 and 4.2. Those are the normals. So in these septic and anaphylactic states, that cardiac index is going to increase. The heart is going to try and squeeze harder, and it's going to try and squeeze faster. Okay. When you have a neurogenic involvement, the body, the heart, doesn't get that sympathetic stimulation. The signals from the brain down to your adrenal glands and down to your vasculature to say increase heart rate, increase contractility, increase vasotone, they can't get there. So that's why you end up with this low cardiac index. So if you see this patient who has a low systemic vascular resistance, low CVP, low pulmonary artery pressures, everything is low, right? They have a mechanism that suggests some kind of distributive shock, but their cardiac index is not elevated. It could be normal. It could be low. You got to be thinking neurogenic shock. Okay, that's the big one that I want to talk about. The other ones, they all pretty much make sense if you look at these. If you have questions, let me know. All right, like I said, I'm not going to talk a lot about the waveforms. You can see all this in the review course when it comes out here in just a few days. Yeah. But what I do want to talk about is we're going to talk about the normals, and we're going to talk about why they are the way they are, and then how you can manage this. Okay. So CVP, this is the one we're going to talk about first. So I'm just going to write this up here, CVP, and I'm going to write the normal value, 2 to 6. Now, sometimes you will see 2 to 8. Anything between 2 to 6, 2 to 8 is considered a normal CVP. Now, let's think about this. If you have an elevated, I'm going to change the color here for a minute. If you have an elevated CVP, okay, your CVP is normal, or your CVP is elevated, what could possibly be causing this? Now, remember the analogy I gave before of the river or of the highway, okay? If you have blood that's coming into the right atria, and remember the CVP is taken either from the tip of the catheter, either just inside the right atria or in the superior vena cava, or depending on where they place it, could be the right subclavian artery or right subclavian vein. But in any case, what you have is a pressure at the tip of the catheter that's reading high. Now, why would that be elevated? Basically, it's a problem with forward flow. Think about the river analogy. Think about the car accident, the interstate analogy. You have blood that is coming in and it can't get out. So if it's coming in and it can't get out, then the obstruction has got to be somewhere in this region or downstream. So it's either here, because if you've got traffic that's coming along, right, it doesn't go normal, and then suddenly you have a sudden increase in congestion. No, it kind of backs up a little bit, right? So the same goes for the heart. So if you were to look at your catheter and you say, okay, well, I have an elevated CVP. Okay, so everything downstream of this right atria could be causing the problem. So what could be causing the problem? Well, it could be a problem with the right ventricle. The right ventricle could be failing. Maybe the patient's having a RV infarct and the right ventricle can't clear blood into the pulmonary circulature. Maybe it's something with pulmonary stenosis. Okay, maybe this pulmonary valve is stenotic and it's obstructing forward blood flow. Maybe this is something like pulmonary hypertension. Maybe this is somebody with a blood clot. Remember, what is one of the most probable causes for acute pulmonary hypertension? It's hypoxia. Remember the pulmonary hypoxic vasoconstriction response? When a portion of the lung tissue becomes hypoxic, it vasoconstricts in order to try and force the blood that is in the lung to the regions of the lung that are getting perfused. This is that shunt physiology, right? So you throw somebody on PEEP, you open up those alveoli, you oxygenate those alveoli, you increase the patient's circulating O2, and things start to improve. Okay, nitric oxide is also a really potent pulmonary vasodilator. So nitric oxide does get used a lot in the hospital to try and correct this pulmonary hypoxic vasoconstriction response. Okay, so pulmonary embolisms, like I talked about. Cardiac tamponade. If the whole heart is being squeezed, then neither of the ventricles can actually move blood forward. So you'll have an elevated CVP. Could be the patient's fluid overloaded. You may need to check their serum osmol. Okay, if their serum osmol shows that they're fluid overloaded, great, give them a diuretic. If the serum osmol doesn't indicate that they're fluid overloaded, don't give them a diuretic, because it's been shown that about 50% of patients who have pulmonary edema are actually fluid dry. It's more of a heart failure as opposed to a fluid overload. Okay, Left ventricular failure. Remember, we know that everything backs up. So if the left ventricle is failing, the blood can't get out, everything is going to back up. So that's how you need to think about this. Where is the pressure elevated, and then what is downstream of that? Okay. Now, if the CVP is, let me go back one. I kind of skipped over one that I wanted to talk about. If the CVP is low, you got to be thinking fluids. I didn't really kind of cover that specifically in the slide because there's really not a whole lot more to be said about that. CVP is a measurement of right ventricular preload. Get that in your mind, okay? That is going to be important. CVP is a measurement of right ventricular preload. Okay? So just like CVP is a measurement of right ventricular preload, a pulmonary capillary wedge pressure is a measurement of left ventricular preload. Now, it's an indirect measurement, but that's still the best way to think about it. It is a indirect measurement of left ventricular preload. So CVP is low, their fluid their fluid dry, give them fluid. That's basically all you need to know about that. It is possible that it is one of those neurogenic or those distributive shock states, and in that case, right, we know that they're not necessarily absolutely fluid dry. It could be a relative hypovolemia. They still need fluid. Okay, there's not enough fluid coming into that right atria. Okay. I'm not going to talk too much about treatments specifically for these various pressure variations. It's going to be very disease specific. We're going to cover that in the course, but you can start thinking once you start thinking about like what could be causing the problem, then you can start targeting your treatment on that. Do they need fluids? Do they need some kind of inotrope? Is this a pulmonary embolism where they need some kind of clot busters, or do they need to go to IR for surgery? So it's going to be very dependent on the problem. And there we go, low CVP hypovolemia. Okay, so right atrial pressures. Now, first of all, I put in here it's not monitored. It's not monitored because we don't want to be spending any time with the catheter tip or the pressure tip in that right atria. And, for one reason or another, it's kind of, I don't really know why, but they don't put a pressure port in the PA catheter that hangs out in that right ventricle. But you do need to be able to recognize a RV pressure. And the reason for that is one of the most critical, well, there's two critical complications that can occur with, there's multiple critical complications that can occur with pulmonary artery catheter monitoring. But one of them is migration of that pulmonary artery catheter into the right ventricle, because it can irritate the ventricle very rapidly. It can cause all kinds of tachyarrhythmias, including VTach. So you need to be able to recognize that RV pressure so that you can immediately take steps to correct the placement of that pulmonary artery catheter. If you think about it, that catheter is fed up here into the right atria, down into the right ventricle. It goes through the pulmonic valve, and then it's just kind of hanging out in here, but it's not anchored to anything, right? So there's no reason why this catheter couldn't fall back in, except for forward blood flow is trying to keep it up into the pulmonary artery. So if something were to happen and that catheter were to fall back into that right ventricle, you've got this whole loop of catheter that is now hanging out in the ventricle, and it can bounce around and irritate that ventricle. So that's why it's essential that we're able to recognize this right ventricular pressure. Okay, so normal right ventricular pressures are 15 to 30 over 0 to 5. Okay, and the reason it's 0 to 5 and not higher, like we're going to see in the pulmonary artery pressures, which we do monitor, is because of that that pulmonary valve. Okay, that pulmonary valve is well, it's not because of the pulmonary valve. I'm sorry. It's because the left ventricle is filling during diastole, right? So it's ejected all of its blood, and now it's passively filling as blood fills in from the right atria. So we have this low pressure. Okay, and it's important to recognize that because the right ventricular waveform is the largest waveform out of all three of them. And you need to recognize that diastolic pressure is going to be close to zero. If you were monitoring a pulmonary artery pressure, right, you're going to see this pressure that's 15 to 30 over like 8 to 12, 8 to 15 is somewhere in there. And then suddenly you have a large waveform and the diastolic pressure is near zero. That catheter migrated into the right ventricle and you need to respond. Okay. So elevated RV pressures, right? You're not going to know this because you're not monitoring, but this just kind of reinforces the concept that I'm talking about. Okay, if you have an elevated RV pressure, then the problem is occurring it's got to be occurring downstream. Maybe it's occurring with the actual right ventricle, but it's somewhere from the right ventricle downstream is where the problem is occurring. And you would expect that the right ventricle, the RV pressure, and the CVP to be elevated because everything is backing up to that RV. Right? If you were to look at the RV pressure, if you could, and the RV pressure was elevated, but the pulmonary pulmonary artery pressure was low, well, then what is between that high measurement and the low measurement? It's the pulmonary artery, the pulmonary valve. So that tells you that the problem has to be with that pulmonary valve. Well, what could be a problem with that pulmonary valve? It could be a stenotic. That's probably the biggest thing that could be causing that obstruction. Now, if the pulmonary artery pressures were not low, well, then you're going to have to look even farther downstream to try and find that problem. So potential problems that could be causing an elevated RV: fluid overload, so there's just too much fluid in the circulating system, a ventricular septal defect. Okay, if you remember, the left side of the heart is a high pressure. If we've got the heart here, that's dumb. Let's just draw it this way. This is Sean's heart. Okay, and you've got a high pressure over here, and you've got a low pressure. Low pressure over here on the right side. Well, if you've got a hole here in the septal wall, as the left ventricle contracts, path least resistance, depending on the size of this hole, could be right across this VSD, and that would give you an elevated RVP. Okay, so keep that in mind. One way you might pick up on that is if you were to auscultate for heart tones, maybe you would hear a murmur across that VSD. Pulmonary hypertension we talked about, pulmonary stenosis, left ventricular failure, pulmonary congestion. So depending on where the pathology is, you're going to have an elevated pressure, everything upstream. Now, if this was a problem with the a stenotic pulmonary valve, everything downstream of the problem is going to be low because not enough blood is getting to the downstream portion. Think about that river. You've got all this water, then it hits the dam, it stops, and then there's just a trickle downstream. Or that highway, you've got a lot of traffic, you hit a car accident, and then you just have a trickle of traffic after the car accident, and then eventually everything kind of catches up to itself. That's how you have to think about these questions. Let me come back here. So, what about a low RV pressure? It's the same situation. If it's low in the RV, check the CVP. If the CVP is also low, then you have a preload problem. If the CVP is high or normal, then the problem has got to be somewhere between the right atria and the right ventricle. And the only option there is your tricuspid valve. So you could have a tricuspid valve stenosis, okay? That's really the only possible answer under that circumstance where you have a low RVP and an elevated CVP. Okay, so what about pulmonary artery pressures? So pulmonary artery pressures, of course, we know that that is a measurement in the pulmonary artery, and we know that the pulmonary artery has an open line of communication across the pulmonary bed and into the left atria. That is an important thing to note because we don't necessarily have to wedge in order to determine what our approximate left ventricular end diastolic pressure is or our left ventricular preload is. Okay. Before we kind of dive into that, the systolic pressure of your pulmonary artery pressure is between 15 to 30, and your diastolic pressure is somewhere between 8 and 15. That's your normal. Okay. Now, why is that the same as your RV pressure? Well, think about it. When the right ventricle contracts, it opens up this pulmonary valve. And so it's an open communication between the right ventricle across the pulmonary valve into the pulmonary artery. Okay? So it makes sense that the systolic pressures are normal. Now, what happens during diastole? The pressures change, the pulmonary valve closes, and now you don't have a drop in blood pressure within that pulmonary artery. So the diastolic pressure is going to be a little higher. Okay, mean pressures are between 10 and 20. You might need to remember that. Now, I said that there is an open communication between the pulmonary artery and the left atria. And I told you that this allows us to approximate that left ventricular end diastolic pressure without actually having to do a wedge. Okay, and it is an approximation. You can estimate. It's generally about 2 to 4 points higher than the left atrial pressure or the pulmonary capillary wedge pressure or the left ventricular end diastolic pressure, whatever you want to call it. There's a zillion names, it seems like, for what this value is. But think about the way blood moves through the heart or through the body. It always moves from an area of high pressure into an area of low pressure. So if the if the left atrial pressure or the pulmonary capillary wedge pressure was the same as the pulmonary artery pressure, we wouldn't get any forward blood flow. So if you think about it that way, it should make sense why the pulmonary artery pressure is just a little bit higher than that left ventricular end diastolic pressure or your wedge pressure. Okay, so what about an elevated pulmonary artery pressure? Okay, let's go back to our analogy. If you've got an elevated pulmonary artery pressure, then the problem has to be either at the pulmonary artery or downstream. Okay, it has to be in front of where that catheter tip is. So things that could be causing this obstruction to forward flow: left ventricular failure, pulmonary disease, mitral valve stenosis, anything that is blocking the normal flow of forward blood flow, or normal forward blood flow, I guess is the way to put it. Patient, again, could be fluid overloaded. This hypoxic pulmonary vasoconstriction. Remember, at this point, we're measuring the pressures from the pulmonary artery across that pulmonary bed, that pulmonary capillary bed, into the left atria. So if the pressure, if the blood flow is restricted going through that pulmonary capillary bed, then we're going to have a backup of pressure because blood is still coming from the right atria and the right ventricle normally, assuming that we don't have multiple problems here. Okay. High systemic vascular resistance or pulmonary vascular resistance. We already talked about the pulmonary vascular resistance, the pulmonary hypoxic vasoconstriction response. It could be a pulmonary embolism, anything like that. If you have somebody who is in say a cardiogenic shock state, and maybe they're improving, or they're in the ICU for sepsis, and they're on massive vasopressors, okay, then that increase in SVR could be causing a backup through the left ventricle into the left atria, through the pulmonary bed, and back to that pulmonary artery. Okay, You just have to think about what might be going on with your patient and what is downstream if you've got elevated pressures. Okay, ASDs and VSDs as well. Remember, the left side of the heart is considered high pressure. The right side of the heart is low pressure. And so if you have if you have a VSD or an ASD, then you're going to have a left to right shunt, and that's putting more blood than normal into that right side that's then getting pumped back out to the pulmonary artery. So that would be another reason why that pulmonary artery pressure may be elevated. Low pulmonary artery pressures, okay? Remember, if it's low, the problem has to be upstream. So maybe this is a problem with preload. There's not enough blood coming into the right side of the heart to adequately fill that pulmonary artery. It could be right ventricular failure. Maybe the patient sustained a big MI and it's taken out that right ventricle. So it can't pump the blood adequately into the pulmonary artery. Could be the problem with the pulmonary valve. Okay, if you have a pulmonary valve stenosis, then it could be that there's not enough blood that can actually be pushed through that pulmonary valve to adequately fill the pulmonary artery. Okay? What about something like a low pulmonary artery diastolic pressure? Okay, you've got a normal systolic. So say your pulmonary artery pressure is 25/2. Well, why on earth would your pulmonary valve or pulmonary artery diastolic pressure be 2? Well, it could be that catheter has migrated down in that right ventricle, or perhaps it's a problem with like a pulmonary valve regurg. Okay, maybe that pulmonary valve is regurgitating back into the that right ventricle, and so rather than holding that blood in the pulmonary artery, it's allowing it to backflow into the right ventricle. Okay, another reason why that might be low. So when you can think about it, like I said, from that analogy of the water flowing up against a dam or the traffic, it will help you kind of figure out where the problem is. Okay, pulmonary artery, elevated pulmonary arteries. This is some of the treatment. You'll get this in the review course. But remember, it's just going to be dependent on where the problem is in the body. And then lastly, we have the pulmonary capillary wedge pressure, aka pulmonary artery wedge pressure, aka left ventricular and diastolic pressure, aka pulmonary capillary obstruction pressure. Okay, whatever they call it, they're all the same. Okay. This is a measurement of left ventricular preload. This is measuring the volume of blood that is going into the left atria and filling the left ventricle during diastole. Okay. Now, why would this only measure diastole? Let's think about that for a second. When the heart is in systole, what happens? This mitral valve is closed, right? Blood flow is ejected out through the aorta. So when this mitral valve is closed, the only thing that catheter can actually read is the pressure that is coming into the left atria. If it's measuring the left atria, and the left atria is what feeds the left ventricle, then it is left ventricular preload. Okay, so there is a systolic and a diastolic pressure to both the CVP and the pulmonary capillary wedge pressure, but because it's so small, it's not really measurable. I mean, we're talking about a normal value for the pulmonary capillary wedge pressure between 4 and 12, and with the CVP between 2 and 6, that it's very difficult to measure. So it's reported as a mean. Okay, so the mean pressure over one entire cardiac cycle is only between 4 and 12 millimeters of mercury, not a whole lot. Okay, but that is going to give you a an idea of how much blood is actually preloading that left ventricle. Now, we talk about it being left ventricular end diastolic pressure. Okay, so that is because we can only get a measurement of the left ventricular pressure when the ventricle is in diastole, when that mitral valve is open. Okay, because remember, what is obstructing flow, or what valve is there between the left atria and the pulmonary artery, and in this case, the pulmonary bed? There is none. It's an open communication, okay? There is no valve. So it's looking across that pulmonary bed. Remember the catheter? You've got the catheter that's inserted into the pulmonary artery, and you've got this balloon that sits right here, and the pressure sensor is at the tip of that balloon. So it's everything downstream. You get this catheter that is fed up here into the pulmonary artery, and then it obstructs right here, but the tip is hanging down. So it can't see anything upstream. It's blind to everything upstream. It's looking downstream into this pulmonary bed. So it approximates left ventricular function. Okay, normal value is 4 to 12. We already talked about that. The pressure is obtained during the inflation of the balloon. You're going to get this in the course, but I'll tell you the balloon should never, ever, ever be inflated with more than 1.5 cc's of air. If you are inflating the balloon and it wedges, you get a wedge waveform. It converts from your pulmonary artery waveform to your wedge waveform with less than 1.5 cc's of air. That catheter has migrated deeper into the pulmonary artery, and you absolutely do not inflate that balloon anymore. Deflate it immediately, and then call your receiving physician. Check your patient, make sure that they're not showing any kind of signs of a pulmonary embolism, because if so, it could be obstructing blood flow to that pulmonary bed. You might have to actually pull that catheter back out of the artery. The other thing is there's respiratory variation, and I'm just going to throw this in here real quick. You'll get it more in the actual course, but respiratory variation, right? We're measuring pressures, and we know that the lungs inflate and deflate by pressure changes. So if the ventilator delivers a breath, then the pressure goes up within the intrathoracic pressure, and the patient gets a breath. If the patient is not intubated and they are spontaneously breathing, the patient takes a breath, the intrathoracic pressure drops, and air is passively pushed in from the atmospheric pressure into the lungs. So when you are monitoring this pulmonary capillary wedge pressure, what you'll see is this respiratory variation, okay? If the patient is intubated, I want you to remember ventilator valley, patient peak, okay? You want to measure the pressure at the end of exhalation. So if it's a ventilator valley, and we know that the ventilator is positive pressure, then we expect that when the patient receives a ventilator breath, that the pressures are going to go up. Okay, so at the end of exhalation is down here. This is where you're going to measure your pulmonary capillary wedge pressure at the bottom of this respiratory variation. Now, the opposite is true if a patient is spontaneously breathing. If it's patient, it's peak. We know that when the patient takes a breath in, we get a negative pressure. It's an artificial pressure. It would show a reduced pulmonary capillary wedge pressure because it is an active process. And then as they breathe out, everything kind of normalizes, right? The difference between atmospheric pressure and intrathoracic pressure normalizes. And so you're going to measure your pulmonary capillary wedge pressure at the peak. Okay, so patient peak, ventilator valley. So some of the causes for an elevated pulmonary artery wedge pressure, heart failure. If your patient has a pulmonary capillary wedge pressure or pulmonary artery wedge pressure, whatever you want to call it, greater than 18, this is considered diagnostic for left ventricular failure. Okay, so just keep that number in mind. Greater than 18, left ventricular failure. This could be fluid overloaded. This could be increased systemic vascular resistance. If you were to look at those numbers and everything from the CVP all the way to the pulmonary capillary wedge pressure is elevated, it could be that this patient has just got their vasopressors cranked up too high, and the heart just simply can't pump blood forward because it's like trying to pump against a cork. Okay, so just keep that in mind. This could be a mitral valve stenosis. Okay, if it is a mitral valve stenosis, then this pulmonary artery wedge pressure does not represent left ventricular end diastolic pressure because you don't have a normal open communication between the left atria and the left ventricle. Okay, it's important to keep that in mind. It could be aortic valve stenosis, anything that is obstructing forward flow. As far as low pulmonary artery wedge pressures go, hypovolemia, right ventricular failure, pulmonary hypertension. Okay, if you have pulmonary hypertension, then you don't have enough blood that is communicating through the pulmonary vasculature, and that tip, which is embedded in the downstream portion, right, if you will, you have this, it kind of looks like an hourglass. This is a terrible way to draw it, okay? But then it opens up again, okay? This is the pulmonary artery. This is the pulmonary vein. This catheter comes in here, okay? The tip is down here, and it wedges, okay? And if this is clamped down, if the arterioles, the pulmonary bed is clamped down, well, this tip is reading everything afterwards. So you don't have enough blood that is coming through the pulmonary capillary bed, and so it's going to be reading low pressures on the outflow side of the pulmonary bed. Okay, pulmonary valve or pulmonary artery stenosis. Okay, could be a problem again with that pulmonary valve. The pulmonary artery is too clamped down. It's too restricted. You don't get enough blood flow. And then your obstructive shock, specifically the pulmonary embolism. Again, you don't have blood that's flowing through the pulmonary vasculature and filling that left atria. Here I talked about the respiratory variation. I think that's really all I want to go over for this right now. I hope that was helpful in kind of clarifying for you a little bit about hemodynamic monitoring. If you have questions, definitely leave them in the comment section. And that's really all I wanted to go over as far as our hemodynamics. I did have let's see, one other thing. Let's see, let me find this here because I wanted to make sure that I kind of hit everything. Oh, yeah, right. So, like I said, my team and I, we are working hard on getting the remainder of the content up for the course. And then I'm starting to transition mentally a little bit. And whenever I have some free time and I can't work on the content for the EPICC Review course, I'm starting to put together the Tips from Crit podcast. I am super excited about this. For those of you who know me and who have been following me for a long time, my main focus has been reaching as many people as possible so that I can help as many people as possible kind of reach this goal that they have, whatever that might be, whether it be just passing your exam, improving your clinical skills, getting ready for an interview, landing your flight job, whatever it might be. And Tips from Crit is just my next project to try and extend the reach and help more people. So you can go to the website, tipsfromcrit.com. I'll show you what it looks like right now. It doesn't have much on here. Matter of fact, it doesn't have anything. But I'm going to just kind of give you a quick little tour around because I'm proud of it, and it's going to be super fun. So here is the website, tipsfromcrit.com. At the top of the page, there's links to the EPICC Review course. So this is for people who might just be finding this, and aren't part of the course. There's a contact page, an about page, and what you will see is as new episodes are posted, they're all going to pop up here on the homepage, so you're not going to have to go hunting for anything. This is going to be the show notes, so you'll be able to come here, you'll be able to listen to the podcast, you'll be able to download the podcast if you want. There will be a button in order to subscribe to the podcast on iTunes and get all of the episodes pushed straight to your iTunes feed. Excuse me. And then there's also going to be show notes. So everything that I talk about in each episode, there will be links to different resources, and then there'll be a comment section. So you'll be able to come back here and ask your questions, leave your comments, engage with the audience, and really kind of collaborate and really grow the knowledge and grow the community. The last thing I want to share here is, you've probably heard me talk about this before, but I just want to kind of put it out there one last time, is the whole idea behind this podcast is to be very engaging, okay? There are podcasts out there that are, the host is just talking and sharing information, and those are pretty good. There are podcasts out there that are interview-based, and those are pretty good as well. There's only a few podcasts out there that I'm aware of, and none in our environment, that allows you, the listener, to become part of the show. Okay? And there's the one that I know of, and it's one that I've been following for a long time, does this in such an excellent way that I had to model my podcast after this. So the idea here is that the episode will be based on a question from the community, from paramedics that are out there in the field, that are listening to the podcast. So you will be able to come here to the website, tipsfromcrit.com, and at the top you'll be able to click this button, ask a question. And this will probably evolve over time. And what you'll be able to do is, if you click this button right here, start recording, you will be able to leave me a question directly from your computer. You can say, hey, Sean, this is so-and-so. I'm calling from so-and-so, and I have a question about cardiac hemodynamics. I just don't understand CVPs. Can you explain to me why the CVP would be high or why the CVP would be low? And if the CVP is high, what would be causing that? How would I treat that? You could leave me a question about distributive shock and say, hey, I just don't understand how the hemodynamic parameters would be different between anaphylactic shock, septic shock, and neurogenic shock. I will take that question, I will put that into the podcast, I will play the question, and then I will answer the question. And for those of you who leave me a question, I've got a really cool thank you gift that I will send you, as just my way of saying I appreciate you calling in and being part of the show. So do I want to show you? I'm going to leave it. I will show you in an upcoming live broadcast on the Facebook EPICC community course, community page. I will post an image of what I have for you. So as I get ready to launch the podcast, I'm going to just ask you all to think about what it is you're working on right now. It doesn't have to be related to the FPC or CCPC review course. It could be anything related to our community. It could be clinical practice. It could be job interview strategies. It could be test taking strategies. It could be, how do I get ready for the exam? What is the exam process like? It could be anything. Head on over here, tipsfromcrit.com, click on the ask a question at the top of the page, and then send me your voice message. And I will start including these into some of the first episodes of the podcast, which I'm hoping to have up and on iTunes, hopefully by the 1st of October. Right? That's my goal. So have the podcast up by the 1st of October, have the audio download for those of you who are getting the audio download available, and we're going to have almost all of the lessons up hopefully by the 1st of October. So stick with me. You guys are awesome. I sure do appreciate everything that you are doing for your patients, the EMS community, the FOAMed community, FlightCrit, and our awesome community that we have here with FlightCrit and the EPICC review course. Remember to leave your questions in the comment section below. If you're watching this on the replay, if you are going to catch this on Facebook, or if you are on the Facebook group and you want to leave me a comment there, you can do that also. Or you can email me, sean@flightcrit.com. Or better yet, if you're not going to leave it in the comment section for this show, go over to tipsfromcrit.com, click that button at the top and send me a voice message and let me know what you think. All right, guys, I sure do appreciate everything. That's been about an hour, and we'll talk to you next month. Bye for now.